Hey everyone, and welcome to this explainer built specifically for you, the MRCOG candidate. I am absolutely thrilled to guide you through this material today because we're going to completely synthesize the exact clinical data and recommendations you need to master the 2021 RCOG guidelines for amniocentesis and chorionic villus sampling. If you are looking for the high-yield facts completely separated from the noise, you're in exactly the right place. Let's get into it. Today, we'll be mapping out baseline miscarriage risks, gestational timing, the complexities of multiple pregnancies, third trimester nuances, and finally, managing viral transmission risks. All right, part 1, miscarriage risks and counseling. So you're sitting down with a patient, right? Updating their baseline knowledge on invasive testing risks is always step 1. The data has evolved a lot over the past few decades, and your counseling has to reflect the current reality. Women absolutely must be informed that the additional risk of pregnancy loss following either amniocentesis or CVS by a trained operator is likely to be below 0.5%. This is a massive shift from older historical data. It's a grade B recommendation, and it's a total game changer that you need locked down for both your exams and your daily practice. Now, you know how it is. Patients usually laser focus entirely on the risk of miscarriage. But your consent process has to be comprehensive. Beyond pregnancy loss, there are specific secondary risks you must memorize. You've got to tell patients there's up to a 6% chance of needing a second sampling or repeat procedure. There's also a 2% rapid test failure rate and a 0.5 to 1% failed cell culture rate. Also, notice that maternal cell contamination sits right at 1 to 2%. It's all about giving them the full picture. And this lays out the exact grade B evidence backing up what we just talked about. It's a great reminder that the 0.5% risk isn't just a blanket guarantee for everyone. The risks dynamically increase with less skilled operators, or if the fetus already has an underlying chromosomal, genetic, or structural abnormality. So always contextualize the risk for the specific patient sitting right in front of you. Moving right along to part 2, gestational timing guidelines. Timing is huge. It's a highly testable area for MRCOG candidates, and getting this wrong in an exam, or honestly, worse, in actual practice, has serious consequences. Let's map out the absolute earliest limits on this timeline. CVS must never be performed prior to 10+0 weeks, no exceptions. However, to reduce technical challenges from thinner, less developed placental tissue, it's ideally performed from 11+0 weeks onwards. For amniocentesis, the hard line in the sand strictly starts at 15+0 weeks. So why the hard lines in the sand? Well, it's rooted in specific, testable pathology. If you jump the gun and do a CVS before 10 weeks, you're looking at a possible association with oromandibular and limb reduction defects. Conversely, doing an amniocentesis too early, before 15 weeks, significantly bumps up the risk of the fetus developing talipes equinovarus, which is clubfoot, and it increases your risk of cell culture failure and needing multiple needle insertions. All right, Section 3, navigating multiple pregnancies. Throw twins into the mix and the baseline stats completely shift. You absolutely have to contrast these figures clearly in your clinical practice. While a singleton loss risk sits comfortably below 0.5%, for a twin pregnancy, that additional risk of pregnancy loss basically doubles to approximately 1%. The background risk of pregnancy loss in twins is already higher, so our counseling just has to transparently reflect this reality. Looking directly at this grade B recommendation, the message is crystal clear. Comprehensive counseling and precise pregnancy mapping are absolutely paramount before a needle ever even touches the skin. You simply cannot wing it when there are multiple fetuses involved. Here is the exact game plan you must follow when mapping twins. First, always use lateral, meaning left and right, or vertical, meaning upper and lower, orientation. Never, ever label fetuses numerically like twin 1 or twin 2. Why? Because it's just not reproducible if another clinician takes over later. And step 3 is crucial. The operator performing the invasive test must also possess the skills to perform a selective termination if it ends up being required. It's all about ensuring accurate, continuous fetal identification throughout the whole patient journey. On to Section 4, third trimester procedures. When you push into the third trimester, which is usually for indications like late-onset anomalies, suspected infections, or fetal growth restriction, the entire complication profile shifts. Severe maternal complications are pretty rare, but you need to accurately counsel patients on what to expect this late in the game. You've got to mention a 3 to 4% risk of preterm labor before 34 weeks, plus warn them there's an increased likelihood of bloodstained samples hitting around 5 to 10%, and a 5% chance of needing multiple needle insertions. Now, take a look at this. The impact of advancing gestation on our lab results is honestly wild. The crucial point here is the dramatic escalation in cell culture failure. We jump from a baseline failure rate of just about 2.1% in the early third trimester, all the way to a staggering 40.6% between 36 and 40 weeks. That is massive. Your overall average failure rate in the third trimester is about 10%, so you really have to manage your patient's expectations regarding getting a conclusive results.
Let's hit Section 5, Managing Viral Transmission Risks.
This area of the guideline is super algorithmic and highly testable. I strongly suggest you commit this exact table to memory. For HIV, the risk of mother-to-child transmission is minimized to very low levels if the mother is on highly active antiretroviral therapy, or HAART, and has an undetectable viral load. For hepatitis B, transmission spikes significantly if the viral load exceeds 6.99 log 10 copies per mil. And finally, based on the limited data we have, there's currently no evidence of transmission risk for hepatitis C during these procedures. This nicely illustrates the grade C evidence driving those clinical protocols. The big takeaway here, if the viral screening results are completely unknown, the invasive test should be delayed until the HIV status can be firmly determined. You always have to weigh the indication for testing against the individual risk of viral transmission.
Finally, Section 6, Maintaining Competency and Clinical Audit.
Knowing the stats is honestly only half the battle for the MRCOG requirement. You've also got to demonstrate a solid understanding of clinical governance and operator competency. To maintain good practice and ensure patient safety, the guidelines stipulate that operators should ideally complete or supervise a minimum of 20 amniocentesis or CVS procedures every single year. This is the gold standard benchmark for keeping your ultrasound and needle guidance skills sharp. And you can't just do the procedures and forget about them. Continuous departmental audit is mandatory. You need to be tracking your multiple insertions, your culture failures, and your bloody taps. But here's the absolute major red flag you need to watch for. A formal review of practice is completely mandatory if an operator's annual loss rate of structurally normal babies ever exceeds 3% for either amniocentesis or CVS. As we wrap up this explainer, I'm going to leave you with a really critical question for your own clinical governance, whether you're studying for the MRCOG right now or running a full fetal medicine unit. Is your unit actively tracking the 14-day procedure-related loss rate to ensure it stays below that critical 0.5% threshold? Knowing the data is one thing. Rigorously proving your department actually meets the standard is a whole different ballgame. Keep this in mind, keep studying, and I hope this deep dive makes conquering these guidelines a whole lot easier.